Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arora, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 413 of our pharmacotherapy series, which majors in lower gastrointestinal disorders. The next clinical case reads, TCJ, a 30-year-old man, was well until 18 days ago when he experienced crampy right lower quadrant abdominal pain associated with an increased frequency of semi-formed stools, that is 4 to 5 per day. The pain was episodic at first, exacerbated by meals, and somewhat relieved by defecation. During this time, TCJ experienced anorexia and a 10-pound weight loss. He denied any change in vision, joint pain, or the appearance of skin rashes. He has not traveled outside the United States or taken antibiotics recently. Physical examination is essentially normal, except for soft, loose, watery stools that are streaked with fat and positive for occult blood. The abdomen is tender on palpation of the right lower quadrant. Vital signs include a temperature of 37.8 degrees Celsius, pulse of 100 beats per minute, and blood pressure of 135 systolic 75 diastolic. He is 180 centimeters tall and weighs 80 kilograms. Pertinent laboratory values include the following: a hematocrit of 28%. Hemoglobin of 9 grams per deciliter. A WBC count, 14 times 10 power 9 per liter. An erythrocyte sedimentation rate of 60 mm per hour. Results of sigmoidoscopy and rectal biopsy are negative. Stool cultures and toxin studies for Clostridioides difficile are negative, as is the examination for signs of trophozoites. A barium enema shows an edematous ileocecal valve and a terminal ileum that has a nodular irregularity of the mucosa. Follow-up colonoscopy reveals a cobblestone-appearing terminal ileum with areas of normal tissue separated by diseased mucosa. So my first question to you reads: which of TCJ's signs, symptoms, and laboratory data are consistent with Crohn's disease? Describe the pathophysiological basis for TCJ's clinical presentation. TCJ, like most patients with Crohn's disease, presents with the classic symptom triad of abdominal pain, diarrhea, and weight loss. His most frequent symptom is right lower quadrant abdominal pain, which is secondary to an indolent inflammatory process in the ileocecal area. Diarrhea is also a characteristic symptom. However, in contrast to ulcerative colitis, the stools are usually partly formed, and gross blood is generally not visible. If the disease is limited to the colon, the diarrhea may be of the same quality and quantity as that associated with ulcerative colitis. If the disease is limited to the ileum, as it appears to be with TCJ, the diarrhea is generally moderate, with 4 to 6 stools daily. If ileal involvement is significant, bile salt malabsorption may occur, resulting in steatorrhea. Weight loss may be pronounced in patients with long-standing Crohn's disease because of anorexia and malabsorption. Additionally, vitamin deficiencies, including vitamin B12 and vitamin D, are more common in Crohn's disease patients than control subjects. Rectal bleeding often occurs in patients with Crohn's disease, particularly those with colonic involvement, although it is not as common as that associated with ulcerative colitis. Slow blood loss may occur in patients with disease limited to the small intestine, which may cause occult blood-positive feces and, eventually, anemia, as illustrated by TCJ. Massive hemorrhage is usually a late complication of Crohn's disease and is generally caused by transmural ulceration and subsequent erosion into a major blood vessel. TCJ's leukocytosis and increased ESR demonstrate that, like ulcerative colitis, Crohn's disease is a systemic disease. Extraintestinal manifestations such as arthritis, liver disease, and skin rash occur in Crohn's disease with the same frequency as ulcerative colitis. However, some types of extraintestinal disease appear to be more common in ulcerative colitis, e.g., primary biliary cirrhosis, than Crohn's disease, e.g., pyoderma gangrenosum. Most patients with Crohn's disease have recurrent, symptomatic episodes of pain and diarrhea with gradual progression of their disease to shorter and shorter asymptomatic periods. Although the clinical course is generally progressive, 10% of patients will remain essentially asymptomatic after a few acute episodes. Other patients may only manifest a slight fever for years until a late complication of the disease, such as fistula formation, develops. Alternatively, Crohn's disease may be rapidly progressive. My next question to you reads: what agents can be used to induce a remission of TCJ's Crohn's disease? Because the clinical course of Crohn's disease varies among patients, the management of this disease must be individualized. The anatomic location of the disease is also an important determinant of therapy. Most investigations evaluating the treatment of acute symptomatic Crohn's disease have ignored this factor and are therefore difficult to assess or compare. Next, we will look at corticosteroids. Corticosteroids are the most widely used therapeutic agents for the treatment of active, symptomatic Crohn's disease. A systematic review of the literature confirms that steroids have a valuable role in remission induction. Landmark studies have demonstrated that approximately 60% to 80% of patients with active Crohn's disease will respond to a course of corticosteroids. These agents seem to be particularly effective in ileal and ileocolonic disease and can induce remission in even moderate to severe Crohn's disease. Budesonide is also recommended in current Crohn's disease guidelines for active mild to moderate ileocolonic Crohn's disease. Let's now consider 5-aminosalicylic acid. Although previously used extensively for mild to moderate Crohn's disease, current trial data and expert opinion have limited the role of 5-aminosalicylic acid drugs to mild active colonic Crohn's disease. A large meta-analysis comparing 5-aminosalicylic acid, marketed as Pentasa, versus placebo found a small and probably clinically insignificant treatment benefit. We will now briefly look at other induction agents. The immunomodulators azathioprine, 6-mercaptopurine, and methotrexate have an onset of action of weeks to months and are not usually appropriate monotherapy for treatment of a Crohn's disease flare. Infliximab is effective for both active and quiescent disease. It can be used alone owing to its rapid onset. A recent landmark study found that early aggressive use of infliximab, with or without azathioprine, was associated with both corticosteroid-free clinical remission and mucosal healing in patients with moderate to severe Crohn's disease. Newer agents have been approved. Clinical studies have suggested a roughly equivalent symptom response between adalimumab and infliximab, and because the former drug is also a potent TNF-alpha blocker, similar safety concerns and adverse effects have been shown between the two agents. Efficacy has also been demonstrated in the treatment of fistulating Crohn's disease. One potential advantage of adalimumab is its ability to be self-administered subcutaneously by patients. Certolizumab contains only the antibody receptor for TNF-alpha bound to polyethylene glycol to increase its duration in the body. Currently, it is only approved for both inducing and maintaining remission in Crohn's disease. A pre-filled syringe is now available for self-administration. Infection and other adverse effects have been reported in clinical trials that are similar to other TNF-alpha blockers. Two randomized controlled trials have found that natalizumab may be beneficial for induction and maintenance of remission of moderate to severe Crohn's disease in a small subset of patients, but at the increased risk of developing progressive multifocal leukoencephalopathy, abbreviated as PML, a potentially fatal adverse effect. Thus, natalizumab should be reserved as a last-line agent. Furthermore, patients are required to be enrolled in a mandatory patient registry program, abbreviated as TOUCH, to receive the drug and should avoid concomitant immunosuppressive therapies. In 2014, vedolizumab was approved for inducing and maintaining remission of moderate to severe ulcerative colitis and Crohn's disease in patients who have failed TNF-alpha therapy. There were no cases of progressive multifocal leukoencephalopathy observed in clinical trials, and the medication does not currently require a restricted distribution program. Certainly, the added expense and risk of using biologics earlier in this population needs to be weighed against the possibility of longer periods of remission and avoidance of surgery. An additional concern is reports of hepatosplenic T-cell lymphoma in young men receiving either azathioprine or 6-mercaptopurine with or without concomitant infliximab, which is usually fatal. After 4 weeks of prednisone 40 mg daily, TCJ experienced fewer symptoms of Crohn's disease. He has 1 to 2 well-formed stools a day, increased appetite and weight, decreased abdominal pain and tenderness, and normal body temperatures. So my question to you reads: should prednisone be discontinued? What agents are effective in maintaining remission of symptoms in patients with Crohn's disease? Let's briefly discuss corticosteroids. Once prednisone has induced remission of active symptomatic Crohn's disease, attempts should be made to taper the drug. The tapering schedule is usually fairly slow. Typically, a dose reduction of 5% to 10% per week, taking several weeks to months to complete. Several studies have demonstrated that corticosteroids are ineffective in maintaining remission in Crohn's disease, and many patients continue to have active disease while receiving therapy. However, a significant subset of patients, 25%, with Crohn's disease requires chronic administration of corticosteroids to prevent recurrence of symptoms, termed steroid-dependent Crohn's disease. Given the poor long-term adverse effect profile of steroids, many clinicians attempt treatment with other modalities to maintain remission. Let's now ponder between choosing 6-mercaptopurine or azathioprine. Both 6-mercaptopurine and azathioprine have a major role in maintenance treatment of Crohn's disease, particularly as a steroid-sparing strategy. Recent guidelines recommend the use of 6-mercaptopurine and azathioprine in most relapsing cases of Crohn's disease, regardless of anatomic site, and for both severe and steroid-dependent disease. Provided patients are appropriately monitored, these agents are safe with a favorable risk-benefit ratio. Both 6-mercaptopurine and azathioprine are the first-line immunomodulators used in Crohn's disease. Should these agents be ineffective or not tolerated, either methotrexate or infliximab can be used to maintain remission. The top-down strategy of starting TNF blockers earlier in the course of disease is currently under debate. Recent findings have prompted experts to increasingly advocate initial therapy with biologic drugs in high-risk patients with moderate to severe Crohn's disease, top-down therapy, rather than initiating after other agents have failed. Some experts believe that infliximab should be used earlier in the course of relapsing disease, especially in patients with fistulae. In summary, TCJ's prednisone should be tapered as suggested previously and then discontinued if possible. As the tapering regimen is begun, TCJ should start 6-mercaptopurine 120 mg, that is approximately 1.5 mg per kilogram per day, or azathioprine 200 mg, that is approximately 2.5 mg per kilogram per day. This is because of the long onset of effect for the latter drugs, usually 3 to 6 months. TCJ's WBC counts should be monitored regularly, and he should be counseled regarding the signs and symptoms of severe infection, e.g., fever, sore throat, or chills, and pancreatitis, e.g., severe epigastric pain and nausea. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 414.